Hi, this is Brian Kim. I want to share with you case number 169 in the Best Way to Do Cataract Surgery series. This is a patient with a plus 29 diopter IOL, and this is a small eye soft lens. You're going to see easy lens disassembly with double chop and cross chop and mechanical fracturing techniques. Again, when you're dealing with soft lenses, you don't want to sculpt, you don't want to lollipop, you don't want to try to grab lens pieces. When you do that, the lens piece crumbles under the high pressure a vacuum. When you sculpt, the lens just kind of crumbles apart. And so in my mind, this is the most efficient, easy, and best way to disassemble a soft lens. And you can see this is going to be in a small eye, but it doesn't really matter if it's a small eye. This case can be easily executed regardless. So I use a corneal marker to help me center and size a rhexis. And then this is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. And use a cotton tip to help control the eye when I do these maneuvers. This is intracameral lidocaine, and then some intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. Again, this is a small eye, and so you worry about the convexity of the anterior capsule for Capsulorhexis. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then turn the cannula towards me when I'm ready to enter, and then I go in. This is the Haldey-Perkar sharp tip forceps for my puncture style rhexis. I puncture the center. Again, because of the sharp tip, it almost basically functions like a cystotome. I pull the tear towards me, grab the right side of the tear. I go around circumferentially, and you can see I have great control of the rhexis. Despite this being a really small eye, I'm not having any major radialization forces here. Well-controlled, low-profile forceps, minimal OVD egress with these Haldey-Perkar forceps. Finish off the rhexis, burp some viscoelastic out, and this is the Capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, turn the tip back up, decompress on the left side, sweeping underneath the anterior capsule and pushing VSS at the same time. Doing the same thing on the other side, on the right side, and the lens begins to spin. Irrigating the surface of the eye and adjusting the sleeve, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, which creates a little ridge. I pronate my hand and leading off with the tip, I'm able to push down into the epinuclear ridge, slide and rotate the chopper vertically. It's around the lens equator, turning the phaco tip vertically subincisionally, fracturing the lens completely in half, performing the same maneuver around the right heminucleus to perform the cross chop maneuver, lifting that piece up with a little bit of vacuum and then fracturing the lens piece into smaller and smaller pieces and then emulsifying the piece. You can see that second quadrant's already pretty loose, so I just use some vacuum to grab it up, crush it between the instruments, and then emulsify the lens piece. So this is in slow motion, again, pronating my hand, leading off with the chopper tip underneath the epinuclear ridge, which makes sure that I'm underneath the rhexis edge. Again, I'm around the lens equator, turning the phaco tip vertically subincisionally, fracturing the lens, bringing the instruments together, essentially cheese wiring through the lens pieces, and then crushing it completely in half and severing it. Doing the same maneuver, placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip, fracturing the lens against the phaco tip. Again, the chopper is like the knife, and the phaco tip is acting like a chopping block. Lifting that first quadrant up with a little bit of vacuum, and then mashing the pieces with the instruments, and then emulsifying it. Using the chopper to loosen up that second quadrant and turning it, and then using some vacuum to grab it with the phaco tip, and then just crushing it with the instruments and then emulsifying the lens piece. So go ahead and rotate that second heminucleus in front of me very carefully, making sure I don't put too much traction on the zonules. I stopped there because I didn't want to pull too much here, just very gently, but you see it's not really wanting to turn, but that's okay. I'm using the vacuum to just turn the phaco-tip more vertically, grabbing with high vacuum and popping it back up. So again, in that case, it's okay because it's already loose and I've already severed it and separated it from the epinucleus in that situation. Using some vacuum to loosen up and remove the epinucleus, you can see that epinucleus is a little bit stubborn, and that again, that's why that second heminucleus wasn't coming out readily. Because of that traction, there's obviously some adhesions between the epinucleus and the capsular bag. But I was able to tease it out nicely, so it's all gone. Trying to remove that little piece off the cornea. So I take the chopper out, push BSS in, take the phaco-tip out, and I go in with the ironing handpiece. Going after some fine wispy material. I'm still in Cortex mode. Going after, again, some fine wispy material. You will be very careful when you're in Cortex mode and have good foot pedal modulation. You see, I'm not using a whole lot of vacuum pressure here. You don't want to grab the capsular bag accidentally, which can happen if you're not careful. But I'm very carefully polishing, looking for cortical material. Again, this is all in the Cortex mode. Switching now to polish mode, and I'm polishing the posterior capsule in the subincisional area. And sometimes when you start to do that, you'll start to see some fine wispy material that's there. So again, if you don't look for it, you won't see it. And I always look for any remnants that might be on the posterior capsule just to have a really nice clear bag when I finish the case. So still polishing subincisionally. There's some fine material that I'm working with here, trying to tease it out, polishing underneath the rhexis edge as well. So you can see, really easy case, even though small eye, potentially shallow chamber, it was no problem. I have those low profile sharp tip Haldane-Perkar forceps for Capsulorhexis that went great. I performed the double chop, cross chop mechanical fracturing techniques, which also went great. Very easy and efficient lens disassembly, utilizing the principles of mechanical fracturing to cheese wire and cut the lens very efficiently and very easily, very well controlled. You see I'm pulsing BSS into the subincisional capsule fornix, and you can see that there's a bunch of stuff coming out now. So that's why I like to go after, with the polymer tip, going after that subincisional area. You can find some very fine material that's still adherent into the capsular bag subincisionally, and then I use BSS Canada to pulse that material out of the subincisional area. I'm going to go ahead and fill the eye with some cohesive viscoelastic, and I'm going to follow up with a little bit more sweeping in the subincisional area. Sometimes there's still some stubborn area, and I'm able to just polish a little bit more. Again, this is kind of a belt and suspenders, a 1-2 punch, so to speak. You pulse, but then you also sweep. And by doing it that way, I'm able to get really clean bags at the end of the case, making sure I don't have any remnants afterward. Because this is a high-powered lens, I have to widen the incision. And again, this is a single-piece acrylic lens, but again, because it's such a high-powered lens, you have to widen it. It's a really thick single-piece acrylic lens. Going into the capsular bag. Switching to the ironing handpiece. Activate irrigation once I'm in, disengaging the haptics off the optic, tilting, rotating the lens clockwise, removing all the viscoelastic from within the bag, removing all the viscoelastic from the anterior chamber, polishing underneath the rhexis edge as well. Switching to visco mode, you can see all that viscoelastic start coming out at the end of the case. That's usually a very good sign that at the end of the case, if you have all this viscoelastic coming out, when you're ready to remove it, that means you've done an excellent job in keeping the viscoelastic in throughout the entire case. And that's another reason why you have clear corneas postoperatively, because by utilizing less fluid around the cornea, by keeping the fingertip in the central safe zone, you're not only not grabbing iris and posterior capsule, but you're also not grabbing as much OVD. So you have better corneal protection, and again, reduce CDE, and of course, clear corneas postoperatively. So that's why I really advocate for this. Most of my patients post-op day one really have crystal clear corneas as a result of these techniques. So again, this patient had a high-powered lens, shallow chamber, small eye, but again, no big deal. Everything went great. We used a sharp tip Haldane-Perkar forceps, low profile, excellent rhexis control, utilizing mechanical fracturing, double chop, cross chop to efficiently disassemble the lens using a cheese wire effect by getting the instruments around the lens and cutting it into smaller and smaller pieces. Again, you saw the CDE was essentially 0, and this patient looked great post-op day one and continued to do well. So I hope this was helpful to you, and I thank you for your attention.